Welcome to the Equine Vet Connect Podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. Welcome back to the Equine Vet Connect Podcast, brought to you by Countryside Equine Hospital. We're back in the studio today, a little treatment room one. I got Dr. Brown with me. Y'all all, if you tuned in before, you have definitely seen her on here.
Been here a couple times now.
Yep. You know, what do you think? I think one day we should do this in the lobby, like do a fireside chat, sitting in the chairs. I think we're going to
take a tour of the hospital.
We should do that one day too, you know.
Move around.
I like it. Change something up a little bit. You know, it's the same place. I feel like we need to do something different. So, all right. So today we had a listener, Danny R., sent in. She wanted to know about hoof abscesses. You know, sent in the question, want to know about hoof abscesses. At first, I was like, oh, okay, hoof abscesses. And I realized, like, there's a lot going on here.
There is, and it's probably one of the most common emergencies that we see.
It is, and I think the phrase that gets used so often is, oh, it's just an abscess.
It's just an abscess. It's not.
It's
it
not.
Never is.
And you know, that's what I thought about.
Is it.
Yeah, like, when I put on, like, hoof abscess, I was like, that's just an abscess. Like, no, there's a lot more.
Oh, yeah.
So,
and even sometimes what you may think, oh, it's just a foot abscess, we actually do a little investigating and it ends up being
not
something
just a foot abscess.
Yes, something very far from a foot abscess.
You know, I do like hoof abscesses. I'm a podiatrist, you know, so
it's like your bread and butter. So.
Exactly. And when they go south, I get to do some cool stuff. So we're going to talk about regular abscesses, intermediate abscesses, and we're going to talk about what happens when it's not just an abscess. First thing, what does an abscess look like? I tell most people, we get a call and they're like, my horse is crippled, I think he broke his leg. It's going to probably be a foot abscess.
Yeah.
90% of the time.
Yes.
These horses are cripple lame.
Lame. Because I think what's something that's important to remember is that horses are designed to basically be running around on their middle finger.
Yes.
At all times. So if you've ever, cut your nail or, gotten something stuck underneath your nail, you can attest to that is super painful.
Yes. I had gout once. Actually, more than once.
Oh, my.
And I can tell you. Interesting enough, I actually went out to look at a horse that had a foot abscess, and I was limping around three-legged lame. And the customer, her husband was the doctor, and she's like, what is wrong with you? I was like, I don't know. It's like, he'll see you. I was like, I can't ask it. No, he'll see you. Well, lo and behold, I fixed the horse, and then I found I had gout. And I can imagine it was very similar pain because I was crippled.
Yeah, it hurts.
So, yeah, it's probably one of the most painful things horses go through. The other interesting thing is people are like, what? He was fine an hour ago, and now he's crippled. They didn't come on that fast.
Yeah. They
can come on fast. Some of them are kind of a slow build, but a lot of them, they could be fine that morning, three-legged crippled that night. I've seen them fine at dinner, crippled at night check.
Oh, yeah.
So they can come on pretty quick.
And they can be, it can become like a full body pain response.
Yes.
I got called out once to a horse that they thought was colicking because I was just throwing itself on the ground. It was just full on, just not having a good time. And it had, stopped pooping. And they were like, oh my gosh, this horse is colicking. Well, come to look at the horse and it's walking around on three legs. And I'm like, what's up with that?
Yep.
And they didn't really notice. They were too worried about the colic signs. And then I lance this abscess open. This horse takes this sigh of relief and all the colic signs are gone.
Yeah.
I'm like, oh my goodness.
I've had him laying down in the stall. Moaning, had him down in the field moaning, would not get up. You're going out, it's a down horse, don't want to get up, and you're like trying to figure like, what is wrong with you? Because vital signs are normal.
Yeah.
And so then you're like, well, let me grab some hoof testers. Sure enough, you find it. And like I said, that pops. All of a sudden, this horse is like,
yeah,
that's good. Life is good.
And as quickly as they'll come on, they will go away
Yep.
that quickly too. I mean, it's like night and day once you open that up. And
Yep.
because I think the whole, again, with kind of going back to the anatomy, the hoof is very unique because there's not really any room for tissue expansion down there. So anytime you have any sort of, pus or foreign object or anything down there, there's nowhere for anything to swell
Pressure.
or sore, and it's just pressure. It's built up pressure, and that hurts a lot.
Yep. Common question we get is like, we go out, horse got an abscess. How long is it going to take to come out, doc? That's like the $1 million question, right? Because I've had some out the next day. I've had some that, Lord, it felt like weeks before we got it out.
Right.
I had a client the other day tell me I told her her horse had an abscess, and I mean, she's really upset. And she's like, the last one took 6 weeks. And I was like, well,
Yeah.
happens. Happens.
It happens. It does.
So-
And, we have this whole idea of they're supposed to take the path of least resistance out of the foot. That doesn't always happen. And sometimes you get these ones that they finally come out. And I was like, really? That's where you decided to pop? Is right there?
I've seen them, like you can see a clearly defined abscess. Like, and that's the other thing we should talk about. Is like, when we x-ray these, a lot of people are like, can you see it? Well, sometimes we can, sometimes we can't.
You can't.
It depends on if the bacteria that's causing the abscess is producing gas or not. If it's a gas-producing bacteria, we can pick up on that gas pocket. So I've seen that gas pocket up in the toe.
You're like, bang.
And you're like, cool, it's going to come out the coronary band. Well, it does back of the heel. Sometimes they blow out the frog. I mean, they our idea of the path of least resistance and theirs, two different
things, right. And
another common thing is hoof testers. They're like, well, he didn't respond to hoof testers.
hoof
Don't
testers
always.
will lie. Yep.
They will definitely lie. Because a lot of times say, hey, I had the farrier out. He couldn't find anything on hoof testers. We come out, we block the horse. For those of you who don't know, you're going to hear us talk a lot about that when we talk about lameness as nerve blocks. We're able to go in and put a local anesthetic like a lidocaine over the nerve and block that area so they don't feel it. Gives us an idea of where the lameness is coming from. So we go out, we block this horse's foot, and lo and behold, there's an abscess. I didn't get anything on hoof testers, farrier didn't. We can still be an abscess. Hoof testers will lie to you.
Absolutely.
So.
Absolutely.
So that being said, we come out, we do find you got an abscess. Radiographs.
Radiographs.
Where do you stand?
I'm a big fan.
Yes.
I am a big fan. Just because, yes, we can assume it's an abscess, but I've taken some that I am convinced is an abscess, and whoop, there's a nail in there.
Yep.
Or there's a broken bone, worst case scenario.
I have seen the same thing. Like, you swear it's an abscess. Had one that's a fractured navicular bone.
Yeah.
Abscess lane, fractured navicular bone. Another one, abscess lane, fractured coffin bone.
Yeah.
Nails.
Nail
Nails.
is super, super common.
Yes.
And you can't always see them.
Right.
You
So
can't always see 'em.
your veterinarian says, hey, we're pretty sure it's an abscess. Let's get some x-rays, some radiographs. Just say yes. It also serves another purpose too, because we're going to evaluate the health of that coffin bone. That's important because, as we're going to talk about a little bit later, it's important because sometimes these will progress to an osteomyelitis and actually have an infection in that coffin bone. So we'll get into that a little bit later about when abscesses aren't just an abscess. Common things we'll typically see: swelling in the legs, very common
Swelling
with these.
of the legs. A lot of times you'll feel heat down in, especially kind of near that pastern, kind of bottom of the foot. Something you might hear us talk about are digital pulses. And this is where if you put your fingers down kind of by the sides of their fetlock, kind of underneath the fetlock, you can actually feel that vein just pulsing. Kind of like too, again, if you take your own nail, if you've ever felt like your nail has a tiny little heartbeat.
Yes,
that's what that is.
Good example.
Yep, you're like, that's what that is. That's your digital pulse.
And it's a bounding pulse. And one of the things I tell people is, if you're not sure if it's bounding or not, good news, they've got 3 other feet. Go check one of those.
Check the other ones. I feel like as I was trying to learn what they feel like, it took having one that had a super bounding digital pulse from an abscess that I was like, That's what that is.
Exactly.
And then you realize that, yes, I have been able to feel that. Because you
Right.
shouldn't normally be able to feel a digital pulse in a horse. If you're in a normal horse that's just kind of hanging out, normally standing on all 4 feet, you really shouldn't be able to feel much of anything.
It should be really faint.
Yes.
You know, if you feel them every day, I can find one about every horse, but I'm feeling those things every day.
Yes.
But if you're kind of new at it, because that's one thing I've seen is people like, I couldn't feel a pulse. Then you're good.
That's okay. Yeah.
You're good.
That's fine.
They're not the easiest things to feel.
No. And
You put it on there and you say, oh, wow, there it is.
if it's,
Yeah.
yeah, that's.
We call that a clue. That's where we're going to investigate.
Yep,
So.
those will hurt, and yeah, they can turn into a big swelling going up the leg. I've had some that they almost look like they've given themselves a cellulitis.
Yes.
Their whole leg is just big and swollen. I'm like, what the heck? And then
Yes.
you find a big old abscess coming out the heel bulb.
Exactly. So what do you do? So we found an abscess. What do we do now?
So we've got this abscess. Our goal is to be, if it's not already out draining, we haven't been able to lance it ourselves, but we're suspecting that it's there. We want to try to get it to come out on its own. And so our best way to do that is to try to use some sort of a drawing agent to get it out. And there's a whole plethora of different things out there. My preferred is Epsom salt or Magna paste, which is basically just a kind of gelatinized version of Epsom salt. I like it just because it kind of creates this environment that allows everything to come out. But I mean, gosh, there's ichthymol and
Ichthymol. So, if you're new to the podcast, I was a farrier before I was a vet. And I used to swear that if there should be a constitutional amendment outlawing ichthymol, because it never failed. Vet comes out, horse owner comes out, slathers this thing in ichthymol, wraps something around it, calls me out as the farrier. I unbutton this thing, and there's just ichthymol smells just smeared everywhere. And I don't know why, but I put my hands in some pretty nasty stuff. Ichthymol is where I draw the line.
because it's like tar.
I just draw the line.
It's just tar. It's gross.
So personally, we don't have ichthymol in the clinic, mainly because I won't allow it.
Yeah.
I won't allow it. I don't know if it's good or not. I don't like it. Don't use it.
But,
So,
yep.
personal preference there. Just like I'm an animal intex person.
Yeah, animal intex. Yep, that's another great one.
Yep. And you'll find, like, we used to use one that's called an overnight poultice. Used to make it out of wheat bran, Epsom salts, little DMSO, and a little xenodine. Wrapped it up in an IV bag with some water. Bandaged it on the foot. Used it a lot when I was in Kentucky. Occasionally I'll put one on. Haven't in a long time. Animal intex kind of my go-to.
Yeah, it's a good one. I mean, and it's nice too because it keeps all the fluid out of the foot as well. It keeps everything in, but it doesn't let anything come out. So if you've got, a really nice rainy day like today, your horse can be outside and they're not going to be drawing more stuff up into their foot either. So.
And I'm with you too. Like, I'd say Magna paste is my number 2 choice. I really like it if the coronary band's involved. I really like it if I think, like, my hunch says this thing's headed for a coronary band. I think it works really good there. So I will use that.
And what about, soaking it every day versus just putting a big old foot pack on there and letting the foot pack do its thing? How do you feel about that?
I will soak, because usually I'm going to put animal intex on if it's not out after about 3 days. We got to take that off, let the foot air.
Yeah.
I'll tell people to soak it then. I think soaking's a great technique. We talk about soaking. We're using warm water and Epsom salts, just a hypertonic solution of Epsom salts. And I'm always asked, like, how much Epsom salt to put in. I was like, use warm water and put it in until it settles out in the bottom. You can definitely do that. You can do that twice a day. If you got the time, great. We can wrap this thing up with some animal intex and call it a day.
Yeah, that's kind of my go-to. I was like, I feel like it's just more user-friendly and I can get people on board for it a little better. It's like, put this on and come back in a couple days, take it off.
And I think, when we put a lot of this stuff on, we're wrapping the leg too, so we're helping take care of that swelling that's in there, which, like I said, that swelling can lead to a cellulitis if we don't get that under control. And the swelling itself is painful.
Yes, it is.
So,
and then with that, what are you doing as far as pain control, or are you doing pain control?
this gets, I get asked this question a lot.
It's a hot topic.
No bute, Banamine, no Banamine. I guess, because I hear people say this all the time, like, I don't want to put them on bute because it'll make it take longer. I think the theory from that comes from it's an anti-inflammatory. If it gets inflamed, it'll move more. I think that's the theory. I look at it as his horse is in pain. If we don't do something to manage this pain, one, like, I took an oath, reduce suffering. I got a medication that helps reduce suffering. We can put this horse on some bute. And I don't really think it makes it take any longer.
No.
What are your thoughts?
If anything, I think it helps them kind of move around a little bit more.
I'd agree too.
And in some of these, abscesses, I feel like once they get a little bit of pressure behind them, it does help kind of actually push them out. Not all of them, but some of them. And I just think they're going to be more likely to, kind of continue their normal routine. If they are outside, they're going to be moving around. They're going to want to eat. They're going to keep doing normal horse things versus if they're standing there and they're painful, they're not going to want to do anything.
Right.
And then that's where we run into, colic and, everything else. Like, once horses get out of their routine, it's not good for them.
I think it's highly unlikely bute does slow down an abscess coming out. And I think the benefits way outweigh. Like, if there is a possibility it may take a little bit longer, I don't think there is. But I think the benefits of, one, getting pain control, preventing the colics. But then also, I agree with you, like, moving around, I think helps.
It helps the swelling. It helps.
It helps get the abscess out.
I think.
And bute's my go-to.
Yeah.
I've tested a lot of different things. I've tried Equiox. I mean, I'm talking about Equiox at high doses. 3 times the dose, twice a day. I felt like it did nothing for foot pain. Some people like Banamine. I still, not a published study, just, I guess, theory according to Dan. I just feel like the bute does a better job on foot pain.
It does. I think it's kind of like, if taking it into our perspective, it's like Tylenol's better for some things, Advil's better for others, right? It's...
And interesting you brought up Tylenol too, because Tylenol's interesting because we've been using it more and more. They did a study, and Tylenol is actually really good for foot pain.
Yes, it is.
I've tried it in other cases. I don't think it did anything. But they've done several studies looking at Tylenol helping control foot pain. And I'll be honest, I've never used it by itself. But layered in with bute, I think it really helps.
It does, especially for a lot of these really, really painful abscesses that are just, taking their sweet time coming out, or they're a little more complex. If I've got them on already a pretty high dose of bute and I'm not able to control it, we'll supplement with a little bit of Tylenol in there too, just to kind of get them through that pain. And
a lot of times I'll kind of spread it out. Like, let's say I got bute at 8 a.m. and 8 p.m. is every 12 hours. I may go in and say, okay, let's do maybe like 10 and 10 with some Tylenol.
And it helps just kind of get them through a little bit,
right when that bute starts wearing off, I've still got some of that Tylenol on board. And I think it helps maintain them without getting into what we call wind-up pain.
Right, exactly.
It keeps us out of that wind-up pain, which I think is important when we're talking pain control. That being said, we talk about relieving pain. I'm often asked, you going to dig it out? You going to dig it out or you not?
Unless I am like 100% convinced that it's right there and I can get it, I'm not going to dig it out. I am just scared that I'm going to hit something that I'm not supposed to. I'm not trained as a farrier. I have no business trimming feet. People ask me all the time, hey, will you trim my horse's feet? I'm like, absolutely not. I don't carry farrier tools on this truck for that exact reason. So if it's right there and I can just scoop it out one little kind of divvy and get it out, then sure. But for me, no, I'm not going digging.
Yeah, I'm not much different. If I can see it on an x-ray and I know right where it's sitting, it's within reach, I've got a good spot to go looking, I may go. But one of the things I saw, especially when I was a farrier, is you would come out and a vet had decided they were going to dig holes in his foot because Yeah, and this is also back before we had X-ray.
Right.
I remember before we had portable X-rays on the truck, like taking an X-ray was not as easy as it is now. And so we'd be relying on hoof testers saying, hey, that thing's right here. Next thing you know, we got a crater in the bottom of the foot. Still didn't find the abscess. It eventually blows out the heel bulb or the coronary band.
Right. If you go digging, it's not gonna come out there now. You've scared it away almost.
Exactly. And then now I've got this hole in the bottom of the foot. People want to get into the horse show. Their horse is lame, but we got the abscess is out. But now we're dealing with pain from the hole we got in the bottom of the foot. So I always say you need to be 100% certain you're going to hit it.
Yeah.
You need to know where you're looking. Know you can get it. And there's certain not landmarks, but there's things I'll see on a foot that'll indicate, hey, I think I can dig this out. Again, I got an X-ray sitting there. I got hoof testers telling me to look here. I got an X-ray that agrees with it. Looks very superficial. Looks like I can get it. I've got some separation of the white line, or I've got a possible track I can follow on the foot. I got a lot of things in my favor that say, hey, you can get this with being minimally invasive. I don't want to cut a hole.
I've had some where I literally just pop the hoof testers on and it goes. I'm like, oh, okay.
Those are the best.
Those are the best. I was like, well, there it is. So
drain out beautifully.
Yeah, and then I'm like, all right, just get all the bad stuff out. And I'm like, all right, we're good to go.
That's it.
But actually, we're not good to go. So I think that's important, kind of segueing into like, all right, we've been treating for this abscess. We got it to open. We're done, right? No, we are not done.
And I think let's talk a little bit about what we've kind of touched on it a little bit. It may seem simple, but what is a foot abscess? I mean, it's a bacterial infection in the foot.
You've had your foot inoculated with bacteria, and then it sealed itself over.
And depending on what bacteria you're dealing with, some of these can be pretty nasty. The Enterobacters aren't fun. Beta streps aren't fun. My nemesis is anything in the Proteus category. When those cultures come back Proteus, it's never a good day. And so you've got this infection, and we get it out and drain it. We're like, okay, we're done. Maybe not. Some of these structures in the foot can get infected by this.
Yes.
Digital cushions can get infected. The most common thing, when abscesses aren't just an abscess, I'd say the most common thing is what we call an osteomyelitis, an infection of the coffin bone.
Yep.
This is where the bone actually gets infected, and the infection is actually basically cannibalizing the bone. Then we're going to find that's a radiograph.
Right. And these are very painful.
Yes.
They're very difficult to treat because the bone already does not have great blood supply.
No.
So we're already, going to be really trying to be aggressive with these. If we're suspicious of this, we're definitely going to be wanting to do all the things for it.
And I think that's why it's important to take that first set of x-rays as well.
Yes.
We'll take that solar margin view that lets us look all the way around the bone. Well, if we're a week into this and we're not getting better, we're going to say, hey, I need to get another x-ray. Just go with it. Do not say no. Get the next x-ray, because we can compare that to the original one and we may say, oh crap. This isn't just an abscess anymore.
Something else is going on, yeah.
Now we've got an osteomyelitis.
Oh, yeah.
When we're dealing with these, being a podiatrist, I look at a lot of osteomyelitis cases. A couple things I think are critical is, one, early intervention.
Yes.
Knowing we've got it. Surgical debridement. So we're going to go in and we're going to actually open up the bottom of the foot, and we're actually going to debride the bone, perform a curette, clean that bone up. They're one of my favorite things to do, because one, it really helps horses, and two, it's just, I know it seems kind of weird, but I just enjoy doing it. I enjoyed that surgery, I guess. And I get to do my favorite thing. One of the things I'm a really big proponent of with really bad abscesses, or an abscess that's progressed to an osteomyelitis, I love maggots.
I knew you were saying it. I was like, it's coming.
Sterile maggots.
Nope.
Love them. They're kind of cool. They're lab grown, where we grow them in sterile conditions. and we get them when they're about a day old. Put them into the wound. They do a lot of good things. One, they only eat necrotic tissue, so they don't eat healthy tissue. So anything we miss with the surgery, the maggots clean up. Some people call it microsurgery. Two, believe it or not, the way a maggot eats is it uses its saliva to digest the tissue and then kind of slurps it up. Their saliva, bacteriostatic. Keep bacteria from growing. The sheer fact of them crawling around on the wound actually it stimulates what we call angiogenesis, or new tissue growth.
Disinfectant.
Yeah, so these guys are great.
They're doing a lot of work down there.
They're pretty awesome.
And they are I've used them in wounds before, and it's amazing. I mean, even just a short amount of time, like, you know, how much tissue grows in it. You're like, oh my gosh, but
once you get used to them, they're not so bad. You can actually go on our I think we got a few videos on our website.
I think we do, yeah.
So,
they're interesting too, because they'll tell you when they're done. Because if we'll put them in there and we'll let them go do their thing, and then every day we'll be changing out the packing. And if you take the little packing off and they burrow back into there, they're like, oh, there's still more tissue in there and they're not done yet. And then one day you take it off and they all come flying out at you. They're like, all right, we're done. There's nothing left for us in here.
Oh, there's sometimes where there'd be like hundreds of them in there the day before.
Yeah.
And you come back the next day and they're just gone.
They're gone. And they get big too. They change in size, which I did not know that the first time that I was doing it. I didn't think about it. And then I was like, oh my God, these things are massive now. Like,
they do get big.
They do get big. They're like, they just spooks you a little bit. Yep. It's just, not my favorite.
I can tell you, I will say, like, the first time I used them, it was a little strange. But when I saw how much good they did, I kind of like the little guys, you know? They're really helpful. They're really helpful.
Dan's little buddies.
I know. I really like the little guys.
Yeah, I'll pass. That can go to somebody else.
And I think this kind of segues us to an antibiotics or no antibiotics.
For your like run-of-the-mill abscess that I'm seeing most of the time, I'm not going to put them on antibiotics. But if I have a case where this horse already has like, you know, a cellulitis going on, or, you know, we've had this abscess and it's been draining for some time, and I'm suspicious that we could potentially get a osteomyelitis, I will put them on antibiotics.
Yep.
And antibiotics they're tough too, because we need to find something too that penetrates that area really well. And
right.
That's a really difficult area to get blood flow to get our drugs to. So we kind of have a really short list of antibiotics that we can use.
True.
For these things too. So I'm really, really careful with them.
And interesting enough, we culture a lot of these abscesses if we think we need antibiotics, and a lot of times these are pretty resistant bugs.
Yeah.
They're causing this.
Yeah.
Like we don't get the ones that
they'll be like, no, throw them on some SMCs and they're good. No, these ones never respond to SMCs.
And I think the other important thing we talk about antibiotics is until that abscess is out, do not put them on antibiotics. Because some people think bute will slow one down coming out. Antibiotics definitely will. Because it's actually going to shrink that abscess. It'll quit moving. It's not putting the pressure it needs. So until that abscess is out and draining, no antibiotics.
I don't do it. No.
None for me.
And for me personally, once I get that abscess to drain, again, if I'm not worried about it being it, I tell people, I'm like, keep that bandage on them. Yep. Keep it covered until that hole is completely sealed over and we don't have any draining out of there. Because I have had it happen to me multiple times where abscess comes out after a few days, we throw the horse right back outside, barefoot, we're good to go, and then like 2 days later, the horse is lame again and it's in the exact same spot, and I'm like, here we go.
No, I agree.
We'll re-inoculate.
The one time, probably the main time I use them is sometimes they blow out the coronary band. They'll actually shred the coronary band when they come out.
Yes.
It looks like hamburger meat.
Yes.
Those I've found the antibiotics do help, because I think at that point it's not the abscess, but I think that coronary band's infected.
Yes.
And that coronary band's really sensitive, so when that coronary band gets infected, I will put them on. And that's one of the times I actually will reach for like an SMZ, a TMS, a Uniprim, just a sulfa, because we're not dealing with something in the foot at that point in time. We're dealing with a highly vascular area of the skin.
Right.
And I think those help.
Those do, yes, those are different. Those, oh God, those are my worst enemy. I hate those. Those just, they take forever to heal. They don't drain right. Yep. Like, they're filthy, like, all the time. Yeah. It's always weather like this that I seem to get them. It's just very rainy, muddy, and they're just covered.
Yeah. And one of the things you may hear, like, if it infects a deeper structure, even if it's not necessarily an osteomyelitis, but we're dealing with, like, we may have really infected some of the corium inside the foot. We may not need to debride, but we need to do an antibiotic treatment. That's what we're going to talk about, what's called a regional limb perfusion.
We were just talking about this today.
Yeah, really cool technique. We use a lot of them. It allows us to use, so I guess let's start off what the procedure involves.
So basically what it is we'll take a full dose of an antibiotic, and we will put a tourniquet on the horse's leg or wherever we're going, and then we will inject that antibiotic directly into their bloodstream, but it keeps it in that region that we've basically blocked off. So kind of in the name, regional limb perfusion. And
you get a lot more perfusion. Like, you know, one of the studies on it, let's say we were to give, and some of these are kind of random numbers, but the ratio will make sense. We measure the antibiotic's ability to kill as what's called MIC, or minimum inhibitory concentration. Let's say we give a systemic dose, we may get 5 or 10 times MIC at that particular tissue. But the regional, we could be dealing with 100 times MIC.
Right.
So we get a really high concentration of antibiotic right where we need it. If it's the left front, I don't need to treat the right hind.
No.
I need to treat that left front.
Right.
And so it helps us overcome some resistance issues. It allows us to use antibiotics that aren't cost effective to treat. Or the other thing is, some of these antibiotics aren't real great in high systemic doses.
Right.
So it overcomes a lot of problems.
It does, and they're very effective too. I've had some really good response with some that I've had them on systemic antibiotics. We're not getting where we need to be, and we do a couple days of regionals, and it's like night and day.
Yes.
They're
big fan of those.
I was talking about it earlier today. I was like, this is like one of my favorite procedures to do. It's just so satisfying.
It really is. And we use it for a lot of other things, different wounds, depending on the area. It's a great technique.
Yes.
So, and typically before we do that, we're going to get a culture.
Right.
Culture a lot because, you know, the most expensive medication is the one that doesn't work. So when you're trying to pick antibiotics, we try to take our best guess. But if we're wrong, you know, we'll send the culture out. If we find out we're wrong, then we can make the decision and get on the right one.
Right, exactly.
So we kind of have a rough idea of what works in this area. And that's interesting too, having worked all over the country. It seems as though different regions have different bacteria that are their nemesis.
Oh, yeah.
Like different E. coli's. Like when I was in Kentucky, Proteus saw it a lot. Down here, it's mainly E. coli's, beta streps. An antibiotic that may work really well in Kentucky may not work as well down here. And it just has to do with the population of bacteria, I think, in the environment.
Yeah.
So
the dirt and the poo and all the things. Yep.
So,
cool.
You know, treatment plates are another thing I like a lot.
Oh, yeah.
So we get some of these abscesses that come out the bottom of the foot. And sometimes, like, we have to go in and open up a spot, and we'll put a treatment plate on the foot. It's just a metal plate that screws onto the bottom of the foot that we allow it to keep it covered. It allows you to get access to treat it, but still keeping it clean. I'm a big fan of treatment plates.
Oh, we've done a lot of treatment plates since I've been working here.
I love a treatment plate. I'll put one on in a hurry. So,
but they're convenient too, and it keeps the environment kind of clean too.
Right.
Especially if you know you have these ones that you are going to be treating for a long time. It's just something nice to kind of keep it together.
It makes it easy. If you got to lavage the wound, you can lavage it really easy. Get really easy access to it. Keep it packed with an antiseptic. Yeah, big fan of treatment plate.
Yep.
Get this question a lot. How can my farrier help?
It's a good question. So I think it depends on, you know, what's your relationship with your farrier like, and, you know, how soon is it? Because, you know, if you're walking your horse up that day, the farrier's here, and, you know, horse is kind of coming in on 3 legs, and they see it, and, you know, farrier says, oh, there's an abscess here. A lot of times, if it's right there on the surface, they can grab it, lance it, we're good.
Yep.
But if that's not the case, you know, if you're watching your horse go and they're going around three-legged and all of a sudden, and you're not sure. I'm always going to say call your vet first, because it could be an abscess, but it could be a lot of other things too.
Right.
And farrier is only equipped to handle a couple of those issues.
Well, and I think that's where I like to talk about a team. Mm-hmm. I probably learned a lot more about opening abscesses as a farrier than I did a vet.
Yeah.
But at the same time, we bring a lot to the table. Vets, we got x-rays. Mm-hmm. What if it's not an abscess? Mm-hmm. We need to know that. And that's where I like to work. I like to work with the team.
Yeah.
People always asking, he's got an abscess, should I pull the shoe, not pull the shoe? I'm kind of 50-50 on that. Mm-hmm. Most of the time, if I don't have to pull the shoe, I'm going to try not to. Because the shoe does give us some protection on the foot. If it's right there, if it's a nail that caused the issue, you may pull the shoe.
You may pull it, yep.
May pull the nail. But yeah, I think that is where a farrier can help, because you got to pull shoes, and sometimes they may be a little better at hunting one than the vet will.
Oh, yeah.
But if it's not an abscess, we guard the hole in the bottom of the foot. And I think that's where the skill of the farrier comes in, too.
Right.
Not every farrier's as skilled.
Right. That's true as well.
So, knowing what your farrier can and can't do.
And a lot of times, too, like when I get called in to see an abscess, they will say, hey, my farrier noticed this, a couple days ago when they were here, and, they said, okay, this is what you should do, but if it's not out, in a couple days, give your vet a call. And I'm like, I think that's, again, that kind of teamwork of, they know their limitations. They can, say, hey, soak the foot for a couple days. If you're not coming back out, then, then maybe just investigate it, make sure there's nothing else going on.
I think it's important, too. Don't put your farrier in a situation that you shouldn't.
Right.
You're asking your farrier at that point to be to diagnose something, to be a diagnostician. That's kind of putting your farrier in a bind. That's not what they're there for. Right. And so don't force them into that bind. Don't make them feel like if they can't do it, it's a problem. When you start getting into looking for abscesses, you're borderline on we're getting into a little bit of surgery here.
Right. Even again, I've been told, oh look, the farrier said it's just an abscess. It's just an abscess. I don't need to worry about it. And then I look at it, and our suspensory is torn in half. So I've had that happen too. So it's and it wasn't just an abscess. On
the same note, I've gone out and seen a big swollen up leg thinking I got a bow tendon, and it was an abscess.
It's an abscess, yep.
So, I think that's the important part is, and if you've listened to this podcast much, you're going to hear about that all the time. It's like, get an accurate diagnosis. Know what you're dealing with.
Right.
Nerve blocks, radiographs, all those things will help.
Yeah.
All right. So, turnout or stall rest?
I think it depends on what's going on. I'm a big fan of, like I said, trying to keep horses in their kind of natural routine. So if they live outside, if they're used to being outside, I let them stay outside. I think putting them in a stall, if they're not used to it, is going to be more detrimental to their mental health than not. And, and I think, again, moving around too, if they're comfortable, we'll do it. Now, if it's, pouring rain and it's just puddles of mud out there, and I might say, hey, bring them back in. This might be a bad environment for us to accidentally re-inoculate our abscess, but, I'm fine with them being out.
I usually say they can go out.
Yeah.
I do worry if they're three-legged and not want to put the leg on the ground. Let's don't turn that horse out.
Yeah.
Because it's not going to move around. It's not going to get to water like it should. It can't get away from, especially if there's other horses that can't get away from them.
That's true, yeah.
So I think each situation is going to...
I think it depends, yeah. I think it very much depends on, the horse and your situation and all that, too.
Now, one of the things I will do, a lot of times we go out and it's an abscess. I think it's closed. Because I've had a lot of them, we put a nerve block in. They finally put pressure on the leg.
Down and it goes, yep.
And it just explodes,
I've had that too, yeah.
And sometimes I'll put a longer term block in there. I'll use something like a Marcaine. I've actually used a little Marcaine with actually some butorphanol combined, and put that in the leg, and I can get almost 8 hours out of that and get that horse some pain control and get him moving around.
Get him moving around and let it kind of come out, yeah.
I get asked about gabapentin a lot. I don't think it works. I don't think it helps. I think Tylenol is the best thing we got.
Yeah, at least for an abscess or for something in the foot, yeah.
And I've actually tried buprenorphine on them. I don't think it really got me much. Tried a lot of that. So there's a lot of, I think if I were to sum up abscesses, like, it depends.
It really does.
It depends.
It really depends. And, is it an emergency? Yes.
Yeah.
Yes, I think it is.
Because if it has progressed to an osteomyelitis, or trying to prevent it from getting there.
Yeah.
And your horse is also three-legged lame. We need some pain control. We need to help this horse out.
And again, especially with these abscesses, very, very rarely is it some insidious onset. It's usually they're fine and then now they're not. So anytime we have a horse that's just acutely three-legged lame like that, get them checked out, because it might be an abscess, but it could be something else.
Another interesting thing is a lot of times these horses cripple, they're sound. I think all the abscess is out. Well, I never saw it come out. You may not. Sometimes you'll get this big hole in the foot, and I've had horses that literally would blew an abscess, and they were like a little sore, but they weren't even that crippled, and I got this big exit at the coronary band. And I've had others that literally came out of a tiny little pinhole that you'll never find. So I think trying to find those exit tracks is a lot tougher than most people realize.
Kind of on that note too, because I know we kind of briefly talked about it with the the whole nail in the foot thing. If say you come out and come grab your horse and you see that there's a big old piece of metal sitting in their foot,
don't pull it.
But I want to pull it, Dan.
Don't pull it.
Yeah, don't pull it.
Don't pull it. We need to know where that thing went.
Because again, a lot of times when we've pulled these nails out, it is a teeny tiny pinhole and we can't find it.
Right.
When we come out and look at it. And so we don't know where it went. Because sometimes it may just go straight into the foot and it won't touch anything, but other times it's scratched up the bone, it's gone into
the deep flexor tendon,
the bursa,
yes.
Coffin joint.
And when you talk about feed, I would say it's a lot like real estate. Location. Depending on where it's located, it's whether like, hey, he's going to be sore, or hey, he's coming in to get surgery.
Yeah.
So I think...
and they can be very, very misleading too. I've had some that they look teeny, teeny, tiny, and then you x-ray them and you're like, oh my gosh, this is a big piece of metal.
Craziest one I ever saw a radiograph of was, those little marker flags that people put out, like if you're like, say, you got an electric dog fence, underground dog fence.
Yeah.
And you got little flimsy wire things that you mark it with. A horse thought it was an abscess, didn't radiograph it. Kept treating it for an abscess. This horse had gotten one of those wires up through the frog into the tendon sheath, and it was sitting there. Like, there had to have been 4 inches of this flag inside this horse's foot.
Oh my God.
Couldn't see anything from the bottom. They radiographed it to find the abscess.
Ugh.
Lo and behold, this thing's got one of those wires in its foot.
Oh my God. Did they get it out?
We got it out.
Wow.
Horse ended up having to go to surgery, got it out, had to flush tendon sheath.
Jeez.
Flush the bursa. The horse
like migrated up?
I guess.
Oh my God, that's
But
nuts.
no evidence of it on the outside of the foot. None at all. So, again, another reason, radiographs, they're important.
Found a shard of a Modelo bottle in the bottom of the foot once.
Really?
Yeah, that's how I learned glass doesn't show up on an x-ray. But
sticks don't either.
No, sticks do not. Yeah, wood doesn't, glass doesn't, apparently. Yeah, but
sticks don't show up either. But yeah, so I think that's it continues to go back to what we talk about all the time on the podcast, like follow your steps, do your diagnostics, do what needs to be done, get as accurate as possible on what you're dealing with, get the information, and then form an accurate treatment plan to know what you're doing. It'll actually save you a lot of time and money in the long run.
And if you're in the middle of treating it and you're thinking, hey, something isn't right, this doesn't seem like it's going the way it should be, that's where you need to communicate with your vet.
Yes.
Because again, some of these things, if the sooner we can get on them, the better.
Yeah, give us a call. Because like I said, it may not be just an abscess.
That's what this title is called. It's
not just.
It's never just an abscess.
So, I can remember some of these horses would get these abscesses, and we'd come back out, again, barely even found the exit hole. And I'm back out shoeing this horse, 4 to 6 weeks later, pair out the sole, and lo and behold, this thing undermined a third of the sole. It was massive.
Oof.
And we didn't find it till that next shoeing.
Mm-hmm.
So, but, I think to wrap things up, if I had to summarize this, don't just assume it is just an abscess.
Mm-hmm.
Do your steps, figure out what it is.
Right.
Don't be afraid to call the vet.
Right.
Use your resources.
Mm-hmm.
So, I just want to thank everybody for tuning in. Dr. Brown, thanks for being here. Hope y'all learned something. Remember, it's not just an abscess. So keep sending your questions. We want to thank Danny again for sending this question in. Great topic.
Mm-hmm.
Keep sending them in. You can DM us. You can text us, call us, send us an email.
Send us pictures of things.
Yes.
We love pictures.
Put some stuff in the comments section. Just remember, anything we can do to help, we just want to make the world a better place for horses. So thanks, and we'll see y'all next time.
Bye.